The topic that Doc Kate and the team invited me to present on today is adherence counseling. I see that after this, you guys are going to be talking about treatment failure and resistance. And I can see why these two topics were paired together, right? Because the best way to avoid needing to deal with treatment failure and resistance is to ensure that our patients are taking their meds and are adherent to their meds from the get-go, which is not as easy as it might seem from the outset. So I've spent a lot of time in the last couple of years thinking about adherence to antiretroviral therapy, and we'll get into that now. Okay, let me see if I can advance this slide. Is that working? Okay. So I think first, before we start thinking about adherence counseling, it's important to just think about, what do we mean by adherence? What is treatment adherence? And as clinicians, it looks like almost everybody here is a doctor or a nurse or a clinician. We mostly think about swallowing pills, right? Drinking our meds as the main definition of adherence. But from the National Institutes of Health, this is the definition. We're looking at, for people with HIV, what adherence means. It means starting treatment, taking your medicines every day exactly as prescribed, and also keeping all your medical appointments. So it's not just drinking the pills, but it's also those other aspects that allow us to be able to be on antiretroviral therapy, right? At SHIP, we have done a project over the last, 7 years or so, called the Connect for Life project, which I hope some of you guys who are part of this this HTTP process have heard of. Connect for Life is an interactive voice response system. It's a telephone support system for reminding people when to take their medications, and when to take when to present to the clinic for their appointments, and to provide patients with health tips and information about HIV, about adherence, about nutrition and health and fitness and everything that goes along with your antiretroviral therapy. And we ran a study for a few years where we followed a cohort of our patients at the SHIP clinic, 462 of them who were participating in the Connect for Life adherence intervention. And we asked them a lot of questions over the course of that study about their adherence. What factors affect their adherence? What made them take their meds? What made them not take their meds? What was going on in their lives? And then we looked at their clinical outcomes as well, right? So, Rad, I was really glad when you put the survey question up. It looked very much like this graph that I'm showing to the group here now. One of the things that we asked people was, what was the main reason, or what are reasons why you missed your meds? So out of the 462 patients on the study, there were 228 of them who reported that they sometimes miss their meds. The other 230 something said they never missed any meds, right? So, and we asked them why. What are the reasons that you missed your meds? And you guys, what you said was correct. The top reason that most people miss their meds, 70-something% of the patients said that they were busy with other things, sometimes, often, or rarely. Some of the reasons that you guys maybe didn't think were high on the priority list, but actually were, is that they simply forgot, or that they fell asleep, or that they were away from home, or had a change in their routine. So a lot of these are just factors. The top factors for why people miss meds is factors that are related to just habits and things that are happening in their daily lives, right? In terms of being able to access the meds, being able to easily take them, and just remembering. One that I wanted to point out to you guys that is, I think, probably more specific to HIV than it is to other chronic conditions, is that 44% of our patients who were part of this study said that they sometimes, or rarely, or often skipped their meds because they didn't want other people to see them taking their medication. And I think that this is a small group of our patients, but it's important to notice because it speaks to the stigma of HIV medication, that sometimes people don't want to be seen taking medication because they might be concerned about the perception of that. And so that's something that we need to plan for when we plan to support adherence, is that people are living in situations where they're dealing with stigma and they're dealing with discrimination. And so that affects their adherence in HIV more than it would in other chronic diseases. The other thing I wanted to point out here in the yellow box is that I think as clinicians, we often worry about side effects, about pill burden, about toxicity. And actually, these are, from the patient perspective, the lowest reasons why they're missing their medications. It's not the most common reason at all. So sometimes what we think about as clinicians and what people think about as patients are not always aligned. So I just wanted to point that out. Okay, so this next slide is about behavior change theory. I'll give you guys a small theory lesson just to spice up your Saturday morning. There is a pretty famous behavior change theory or behavior change methodology that was created by some public health specialists called Mitchie, Atkins, and West. It's called the behavior change wheel. It is a wheel because it's 3 concentric circles, or a series of concentric circles, where at the center of the circle you have your individual factors that can affect a behavior, right? And as you sort of go out on the circles, as the concentric circles, it gets to factors that are farther away from the individual person. So the individual person has a certain amount of agency over behavior change, but then around that is the person's environment. And around that are the sort of public health interventions. And around that are the policy and the social interventions. And when we're looking at behavior change in this lens through the behavior change wheel, we're looking at all of those different pieces that contribute to a person's behavior. So at the center of the wheel, though, is what we're seeing here, what they call the COM-B model, the capability, opportunity, and motivation model. That's that center part where we're looking at the individual person. And with regard to adherence, what we're seeing is for capability, things that related to ART adherence are things like adequate knowledge and understanding of your regimen dosage and timing. That gives you the ability to be adherent, right? Behavioral skills for adhering. That means that you are able to remember, you're organized enough to be able to take your meds, that you have the skill set that you need to be able to do it. Ability to access and acquire medication, that is part of what makes you able to adhere to your regimen. Integrating pill taking into your daily routine, access to up-to-date information about your ART, and ability physically and biologically to tolerate the medication that you're taking. So that's those are some examples of things that fit into the capability aspect of COM-B. The opportunity has to do with things that make the situation easier for somebody who's wanting to adhere, who's able to adhere, to create the opportunity for them to take their meds. So this is things like social support for adherence at home, in the workplace, in your social groups, social cues or reminders to take medication, having the medication physically available when you need it, attending the clinic for appointments and for refills. That is another way of making sure you have your meds there, the correct meds, and they're accessible to you. And then environmental cues or reminders to take your medication. And there are lots of ways that we can ask people or support people with environmental cues. Certainly the Connect for Life intervention would call them and tell them to take their meds at the time when they were supposed to. So they're getting a phone call or an SMS telling them to take it. But a lot of things are just environmental cues, is things like putting your meds in a certain place where they're visible on your bathroom counter or next to your bed or in your kitchen next to the coffee pot, or in a place, in an environment where it cues you to take them. People set alarms on their phones. Those sorts of things are things that improve the opportunity to be adherent. And then motivation, of course, is key. If you don't care about being adherent, then you're not going to. So motivation has to do with habit forming, has to do with overcoming stigma and having that sense of self-worth, that it's, worth taking your ARVs, being able to cope with the stress and anxiety of our lives, and also being able to manage mental health and substance use issues that might affect our motivation, and attitudes about treatment, knowledge of HIV disease, and having a goal. And I think in the context of HIV, often the goal that we're looking at is becoming undetectable, and staying undetectable. It's a very clear goal that they're working toward, which I think it works to our advantage when we're talking about HIV compared to other diseases. Okay. Who needs adherence counseling? Most HIV patients need adherence counseling at some point in their journey. Everybody who's new starting ART should receive adherence counseling so that they can make a plan for how they're going to adhere and think about all of the factors that go into their journey that is going to be a lifelong journey taking ARVs. Other people that need enhanced adherence counseling are usually the people who've interrupted treatment. So we know that ideally with HIV, somebody's going to start on treatment, they're going to stay on it forever and ever, and they're never going to miss a day in their life, and they're never going to miss an appointment in their life. But generally, we're seeing now in this response from a public health perspective as well, that's just not the path. It's not a one-directional unilateral path. People come off treatment. People return to treatment in different cycles, depending on what's happening in their life. And when people return to treatment after a period of interruption, it's really important that we welcome them back to treatment and that they know that we're happy that they're back, and that we do some enhanced adherence counseling to look at what are the reasons that they fell off to begin with, so that we can try to avoid that happening again. And then, of course, the high viral loads, which you guys are going to be going into after this session with me. When you talk about treatment failure and resistance, high viral loads can be a sign of treatment failure, but actually even more often than they're a sign of treatment failure, it's a sign of poor adherence. So high viral load is somebody who, before you start or as you start, maybe in parallel, looking at second line or salvage regimens, you talk about adherence with those folks. I was thinking about regimens and which regimens are more robust than others in terms of viral suppression, but let me pause. Let me not say that right now. I'll talk to that on a later slide. Key messages around adherence counseling. I think it's really important that people understand, what does viral suppression mean? It's a very medical term. Our average person doesn't know what that means yet. They will become very familiar with it, but how do we explain viral suppression in a way that makes sense to our lay people who are patients? U equals you. This is one of the most important messages because it's very empowering. U equals you means undetectable equals untransmittable. So I think one of the things that our patients worry about most is, will I pass HIV on to other people? From a personal standpoint, I think people worry about that a lot. We know that people who have got a suppressed viral load, that their viral load is undetectable, it's virtually impossible for them to transmit that infection to other people. So I think the message that we have a goal to become undetectable, and that's going to protect our partners and our family, and people that we have contact with that might be at risk, is a really important and empowering message. Another key message is what to expect. We need to set expectations. We're going to be taking this pill every day for the rest of our life. It's going to be very boring, but we need to set ourselves up for success. And what is that going to look like? What side effects might we experience? What challenges, apart from the medical parts might we expect along the way? And then we need to have a plan. What is our adherence plan for how we're going to tackle that? So those are the key messages. Now, the main question is, are patients getting the information they need about ART? And we would assume that patients who have been on ARVs for a while already have all this information. They are experts, they're old hats, they know everything there is to know about antiretroviral therapy. We, I think, probably overestimate as clinicians our ability to convey this information, because in fact, most of the research on this, even with patients who are treatment experienced, shows that they don't actually know everything that they need to know about ART. So I think we just need, and I've put here some links to some really interesting papers about this. I won't go into the details here, but the take-home message on the slide is that as much as we try, patients who are taking ARVs every day don't necessarily know everything that they need to know about it. So we need to consider this with our adherence counseling. And maybe also this is related to the caterer, the group of staff that provides the adherence counseling as well, because with clinicians, we don't always have that level of time to spend a lot of time having in-depth discussions with people about answering all of the questions. So is there another group of staff? Are there linkage officers or counselors or adherence counselors, retention counselors specifically that can supplement the information that we share as clinicians? Is something for us to think about. There are a lot of really good tools out there that we can use. So I put this slide here because I want you guys to think out of the box a little bit about how are you going to explain adherence to people. So it's not just the old school, we tell you what to do. It's just a conversation. We download this information to you in a consult room and then expect you to go home and retain all of it. I love these BOK beads. You can see here, it's a really good visual way of showing somebody what the road to viral suppression might look like. It's a visual aid. I would love to hear from you guys when we get to the Q&A and the discussions, what other kinds of visual aids you might use to explain viral suppression or to explain other key messages around retention. There are other things that we use, like these treatment journey cards that have contact details for the clinician or for a counselor that a patient can always reach when they have questions or they have things that they need to talk about, because not everything is ever going to be addressed in that first consult. And so they have really nice messages on them. You can get little pamphlets that fold up. So just think about those kinds of tools that can supplement the conversations that we have about adherence. Okay, and then I also wanted to share with you guys what I think is a really fantastic resource for adherence counseling. If you use this particular job aid, there are many job aids for adherence, but this particular job aid, I feel like it's pretty bomb-proof. It's idiot-proof. Anybody who follows this job aid will hit all of the points that you need to hit related to adherence counseling. FHI 360, they used to be known as Family Health International. They have this EPIC project. It's a global project they're supporting worldwide. I think EPIC stands for something around epidemiological control of HIV. It's one of those things where the letters don't actually line up with the meaning, but EpiControl, FHI is working globally on this. They make these really beautiful flip charts that you could keep on your desk and flip page by page. And if you hit all the pages, then you'll hit all of the messages that are needed for adherence counseling. The link is here. I strongly encourage you guys to go and look at this. It's divided into three kind of broad sections. One is introduction to treatment. So that's going to cover things like, what are your ARVs? How do they work? What is viral suppression? What's your dosage? How often are you going to take it? All of that medical stuff that we need people to know. The second section gets a little bit more or a little bit less medical and a little bit more real life. What are the barriers to adherence that a patient might have, and anticipating those in advance and making a plan? Could it be things like transport to the clinic? Could it be things like the timing of the dose, when you're going to take your meds, social support, family support, those sorts of things, and talking about those up front rather than in a reactive way once somebody has defaulted and we're trying to do our post-mortem on why did they stop taking their meds? Why are they failing? Why are we now dealing with a salvage regimen or a second line regimen? Because we didn't actually anticipate all of these problems they might have along the way. So addressing barriers to adherence is very practical. And then there's a third section in this tool, which I think is also very helpful, which is specifically for those patients who are returning to care after an interruption, and special situations around elevated viral loads, right? So this covers everything. This is what the cue cards look like. So you can see it's color coded. The dark blue starts with the introduction, and then the dark blue to light blue, that's that first section that I mentioned, which is the introduction to treatments. The orange section, you can see these are some of the things I was mentioning earlier. These are things about planning for adherence. So planning to stay on treatment, making a plan, setting a goal, transportation to clinic. How is this patient going to keep their appointment dates? Are their appointment dates going to conflict with their job, for example? If that's the case, what are we going to do about it? Number 8 here says making a daily medication schedule. Number 9 says storing medications. Where are you going to keep them? Are you going to keep them in your purse, in your laptop bag, on your bedside table, in your drawer? Traveling away from home. If you have to travel, if you're somebody who needs to go seasonally or travel for work, how are you going to handle that? If you're changing time zones, how do you move your meds to adjust for that? Number 11 is actually one of the things that I think is the most important, which is identifying social supports. And I realize now I skipped a slide very early on. I'm going to come back to it now. But one of the most important things that we found in a Connect for Life study around adherence was social support. So patients that were in a relationship, whether or not that relationship was with somebody else who's also living with HIV or somebody who's HIV negative, having a partner was strongly predictive of being more adherent. But also, I think disclosure was another issue. So people who had disclosed to a family member or friend their HIV status also were a bit more likely to be adherent. There was an association there. And so I think that one of the themes that has come out from Connect for Life is that social support is really, really important in adherence. There's only so much that we can do from the medical side. And so when we're talking to our patients about adherence, I think we really need to help them identify who is that support network for them that they're going to rely on, that's going to help keep them accountable and help remind them to take their meds and support them through the process. And I'll go back to that other slide that I missed in just a second. Substance use. When we did the Connect for Life study, we found that substance use among HIV patients in the Philippines was much higher than it is among the general population in terms of alcohol use and other drugs. However, that alcohol use and substance use was not really that strongly correlated with poor adherence, except for those that were injecting drugs. Injection drug use was negatively associated with adherence. There was poor adherence among injection drug users. But when we think about substance use, then I think rather than saying that substance use is universally bad and that it's going to mess up adherence, and coming from that assumption, one of the better ways to approach it is to say, okay, if you're going to be using alcohol, you're going to be using shabu, you're going to be using whatever it is, how are you going to fit your regimen around that? How is that potentially going to impact on your ability to adhere, and what's your plan for that? And if that plan is to reduce your substance use, great. If that plan is to do something else around making sure that your substance use and your ART doesn't come into conflict. That's also a way of approaching the adherence message. Handling missed doses. This is something that we always forget to tell patients about, and they never know what to do. So you're supposed to take your dose before bed and you forgot to take it, and now you wake up and it's first thing in the morning, and am I supposed to take my dose, or am I just like, how many hours after my scheduled dose am I supposed to just forget it and wait until my next scheduled dose, versus how many hours after my dose can I still take it? And should I take 2 doses? If I missed my dose yesterday, should I take 2 pills today? I mean, patients always need to know this, and we need to give them that answer. And I think it's one of the things that gets forgotten early on. And then when we get down to the bottom here around numbers 17 to 26, these are the messages for the patients who have missed interrupted treatment. They're coming back, and we need to have that in-depth discussion with them, or people who have got high viral loads, or their ARVs are not working well, and we're looking at switching them to second line. So the cue cards go through all of that. Quickly, I'm sorry guys for flipping on these. Here we go. This was the slide that I missed. The factors associated with our adherence in the Philippines. I just spoke to this now a little bit, but in our cohort of those 426 patients, 79% reported that they were taking more than 95% of their doses over the previous 30 days. So adherence in our group at SHIP Clinic was really good. I don't know if this is reflective of what you guys are seeing in your settings, but at SHIP Clinic, it was looking pretty good. Our patients were starting from a good place even before we started the Connect for Life intervention. We used 95% adherence as the cutoff in this study, because sort of the accepted wisdom at that point is that when you're taking, especially if adherence-based regimens, that 95% of the meds is really necessary to achieve sustained viral suppression. We have better regimens now with fewer side effects that are much more robust in terms of adherence and viral suppression. So if you're putting your patients on these dolutegravir-based regimens, they're going to have fewer side effects, and they're going to have quicker suppression, and the regimen is more robust in terms of the amount of meds that they can miss and probably be okay. So whereas before we were saying you can't miss more than 1 pill a month with dolutegravir, and this is not the message that we want to be giving everybody, but it's reassuring for us. With dolutegravir, if you're missing a few of your pills here and there, the chance that it's going to lead to resistance or high viral load is much lower. Dolutegravir is a much better regimen. So I just want you guys to keep that in mind. Longer time on treatment was associated to lower adherence to ART in this cohort of this 426 folks at SHIP. That is actually in total contradiction to much of the general wisdom around ARVs, which says that the first few months on ARVs is actually the key time to worry about adherence. And then once somebody's established a habit, you don't have to worry about them anymore. In our group, we found that after 3 or 4 years on treatment, people just got tired of it. There was treatment fatigue, and people started to slip a little bit. And so, the odds ratio showed every year that somebody had been on treatment after about the second year, their odds of adhering was reduced, of being highly adherent, over 95%. I mentioned about the relationships, and being in a serodiscordant relationship was highly associated with adherence, because people, I think, are very motivated to protect their partner. They have an HIV negative partner, so they want to get to be undetectable as soon as possible. And then the other thing that was associated with an adherence issue was inconsistent condom use. And I think this is just an association whereby if using condoms inconsistently means maybe perhaps you're not prioritizing or planning around, these kind of health priorities, then maybe taking your ARVs, it just goes hand in hand. If you forget to take condoms, or you're not organized enough to do that, then perhaps that same pattern of behavior we see with ARVs. So I'm going back to the end of the presentation now. Motivational interviewing skills, I just wanted to quickly touch on. We could do a whole very long training on MI, but I just want to introduce you guys to the concept. So when we're doing adherence counseling, it's very important that we use motivational interviewing skills as opposed to a teacher-student or a clinician-patient power dynamic or approach. We want to be using reflective listening, and there are some examples here of what reflective listening is. It's using the you statement. So you hear what a patient says, and then you say back to them in a you statement to try to interpret what they're telling you and check that you've gotten it right. Affirmation, recognizing what a patient is sharing with you and that it's valuable and that it's valid. Questioning, open-ended questions is always very important. Ask, tell, ask. So asking what the client already knows, getting their permission to offer them new information, and then asking them what they think of the information is a really important MI skill that you guys can adapt. Recognizing when clients talk about change and strengthening what clients say about change in terms of their ability to manage a change in their life. We could do, like I said, the whole day, a whole week, probably on motivational interviewing, and we could, as a group, do lots of role plays and scenarios where we could improve our MI skills. We're not doing that today, obviously, in this context, but I just wanted to sensitize you guys to the concept of motivational interviewing and give you guys this resource. So hopefully you guys can go and follow up and work on it going forward, incorporate it into your practice. And then just a last tip around communication traps. There are certain things that don't help us or don't serve us when we're trying to motivate our patients to be adherent. So let's avoid assuming that we know the client better than they know themselves. Telling the client why they should change or pushing the client to agree to a change when they aren't ready is never going to work in our favor. Arguing with the clients, there's really no point to that. Ordering or commanding the client to do something. There are many doctors on this group. I know that doctors like to give an order and hope that somebody will follow it. In this case, that's exactly the opposite of what we want to do. We're going to avoid that. We're going to try to come to a consensus together with our client about what that person will do. Blaming, shaming, or judging. I know this seems obvious, but I will tell you, I hear from clients and patients all the time that they feel shamed by their clinicians for missing a dose or for being late to an appointment or for doing some behavior that the client or that the clinician doesn't approve of. And it comes through all the time. And I know that especially with our older nurses, there's a certain expectation of what the young people are supposed to do. So we need to encourage everybody to remember blaming, shaming, and judgment is just not welcome in the space around HIV care and treatment. Instead of the no-nos that we've listed there, things that we can try is to use open-ended questions to learn about the client's reasons for making a change, to explore what the person's challenges are, why they're resistant to change, and shift the focus if needed. Use double-sided reflection, involve the client in problem solving, and emphasize that the client is free to make decisions for themselves.